It's an emergency war surgery manual. There's not an actual instruction number. And again, who did I tell you writes the emergency war surgery manual? Army.
Alright, so some terms: CASEVAC, medevac, aerial evacuation. So does everyone know the difference between those terms? CASEVAC is from point of injury to that MTF. Right? Once you get them back to that MTF or CCP or what have you, from that point, if you're going to move it from there, it becomes a medevac. Right? Because you're no longer in that combat situation. It becomes an aerial medical evacuation when you're using an Air Force asset like the CCAT. And they usually come in on like the C-130, C-17. I think the other was it KC-135?
Yeah, KC-130.
And those are your fixed wing planes that they use to transport those more critically injured patients or if they have to go further distances. And then en route care, maintenance of treatment initiated prior to evacuation, sustainment of the patient's medical condition during evacuation. So that's when your CCAT team comes into place. Does everyone know what a CCAT is? For those of you who don't, it's a critical care air transport team. It's usually a 3-person team, consists of like an ER physician or general surgery doc, maybe an anesthesiologist. You have a critical care nurse, and usually like a cardiopulmonary tech or respiratory therapist or something along those lines to help with airway interventions. But we'll get to those here in a second. So things to consider for patient entering medevac. So is clean? Is the patient stable? Can withstand transport? All medical interventions are in place and secure, i.e. whatever dressings, tourniquets, things that you may have placed on the patient, you make sure double checking all those are good to go. Patient is securely covered with a blanket along with an aluminized blanket. Why do we make sure that patient's warm? Exactly. So if you've got an excessive amount of blood loss, what is your body not doing? It's not able to perfuse blood adequately, which in turn pushes down your core tips and make sure you keep that patient warm so they don't go for shot. All personnel belongings and medical treatments accompany medical records accompany the patient. So whatever you have for them, you want to make sure it's labeled, put in their respective travel bag or whatever is going to go with them to where they go. Give that to them so they can move forward. Request to transfer patients via U.S. Air Force Aero Medical Evacuation System must also be validated by TPMRC or the theater validating flight surgeon.
Put a star next to that bullet point because they're going to put that as a test question. Who validates the request for transport? And you need to know that it's that validating flight surgeon.
So for patients evacuated from Row 2 MTFs or first group 4 surgical teams, the brigade surgeon determines the evacuation precedence for all patients requiring evacuation from that facility. So consult should be done with the FST's chief surgeon and senior nurse. All right, so implications of aviation environment. So vital signs monitoring, neurovascular check should be tailored due to altitude effects and restricted mobility. Secure airway with a prophylactic endotracheal tube, wounds dressed for delayed primary closure. So AE crew does not repack any of your bandages. So they're going to leave them in place unless sepsis is suspected. CAS must be bivalve. Essentially what that means is that CAS must be cut in half when they're traveling. So if they need to get access to that limb for whatever reason, they can easily remove that CAS and do what they need to do to treat that patient accordingly. Decrease barometric pressure and then cabin altitude restrictions. So consider for penetrating eye trauma, severe pulmonary disease, pneumothorax, air splints, neurosurgical, and thermal stress. Patient movement in ABC environments. Casualties must be externally decontaminated and time allowed for off-gassing of residual chemical agent. Movement may be delayed, aircraft decon time, availability of air crew, quarantinable diseases. What was that country earlier this year they had concerns about? Was it Ghana? They had concerns about Ebola.
I think so, yeah.
So 2 months back, talking about quarantinable diseases, there were some issues where there's operations going on in Africa, and there were people operating in and out of Ghana. And at the time, they were having an outbreak of Ebola. So there are concerns for those Americans going down there. What are going to procedures be for, evacuating them, proper assets can be sent down there, so on and so forth. So that's one of the things, or an example of why things would be delayed. Fortunately, no one was injured during that operation. Everyone came back, saved, no issues, but there were a lot of precautions taken as they were coming back from that country, screening and so on and so forth, just to make sure they weren't carrying any type of disease or anything like that. Medical evacuation presidencies. So A consists of primarily the C-130, KC-135, and then C-17. Aeromedical evacuation liaison is a 4 to 6 person communication team, usually co-located within MTF.
Put a star next to that bullet point, because they like to know what that team is made up of.
Aeromedical staging facilities are generally located at major transit points and manage the administrative processing staging. Patients are normally held only 2 to 6 hours prior to evacuations. They can have up to 100-bed facility. So, and that's dependent upon, your location and where you're at in that facility's capabilities. And those patients are getting transported.
So is the 100-bed facility, that's where they're held by?
So, sweet. Thank you. So I'll give you an example. So, Djibouti. So Djibouti, Africa is, everyone knows Africa is a huge continent, right? So based on operations in an interior distance, a lot of times when there are flights or there are medevacs, let's say further south, from somewhere like Nairobi or Amanda Bay or something like that. They won't necessarily have the space to hold 100 patients there at CLDJ, but they'll come through, be there, hold them for a day or two, or however long it takes for them to process the flights to be able to get that team to come down from Lascaux and then transport them, or the rotator that goes weekly back and forth to Lascaux to transport patients. Most times, once they get to DJ, they're stabilized, and it's just a matter of monitoring them for a day or two, depending on the injuries, before they push them up to launch field for further care and treatment.
So is that housed just for the Air Force? The Air Force is the only one responsible for that, or can Corpsman go to that building?
Go to that billet?
Yeah.
From my experience and what I've seen, it was only Air Force personnel. Now, Corpsman worked intimately, especially the Corpsman worked at the EMF with the AE personnel folks, because they're maybe like a block over from where they are, but they frequently interact with one another and communicate and stuff like that, going back and forth. So you'll have a lot of opportunity to work with them, but I don't think there's necessarily a billet for them. So evacuation presidencies, so urgent priority routine. So everyone knows the difference between each. Do I need to go into detail on those?
Just make sure you star those to know the time frames. 1 hour, 4 hour, and 24 hours. Anything routine usually has 24 attached to it anyways.
Alright, reporting a patient for aeromedical evacuation. So originating physician consults with the local flight surgeon to determine en route care. So that you have an injury, right? You see that injury, you submit the line to your headquarters element, and at the same time, simultaneously, a lot of times everyone's kind of watching this net. People are ancillary in the background, right, working the medevac piece already. So as you get more details and you feed that 9 line to your radio operator, whoever, and they push it back to the op center so they can brief the CO, so on and so forth. A lot of this happens simultaneously. So your respective surgeon is already kind of, if they get his wheels trained, they have these injuries, these are things you want to do. Now, specific to AFRICOM AO, a lot of places where folks are operating out of the outstations, there's a FRIST, an Army FRIST, so an Army Research Surgical Team. This is just a little background information on stuff you need to know. That is embedded there. So they'll go back to that outstation, down the back, don't worry, the heels, pick them up, take them to that FRIST, they'll do whatever they need to do there to stabilize the patient for however long. while still coordinating in conjunction with the AEL and NOS or the area medical liaisons to start coordinating and transport that patient to a higher echelon of care. So when transporting, let's say, for example, you're transporting a patient from Somalia and you want to send them to launch stool. So before they go to launch stool, they're going to go to CLDJ. So they're going to go to Booty. From there, they're going to go to launch stool. So with that, the AEL knows if you're sending the launch stool, one, you need to have an accepting physician. So that's where that communication comes into piece. To send them, once you have that accepting physician there, then you also have to communicate to the EMF to make sure, hey, when they come up to CLDJ before they transfer up to launch stool, that there's a provider there that's willing to accept that patient as well. That makes sense. Alright, so physicians must identify points of contact, verify and test lines of communication, rehearse patient evac drills, to ensure optimal care communication with physician on treatments with patient and plan moving forward within 24 to 48 hours. Ensure patient has enough supplies and medications for transfer, at least 24 hours, intra-theater and inter-theater. Does everyone know the difference between inter and intra? So intra-theater means within that AOR. Right, so within the AFRICOM AOR, let's say if you're going from, you've been stabilized here, down in Somalia, and you're going to CLDJ, they can see you, treat you there at the row 2 that they have there. Most times if you're going back from that country, they'll push you up to launch stool anyway. But inter-theater is just within that AOR, or intra-theater is within AOR. Inter is in between. So when you go from CLDJ to launch stool, now you're going from AFRICOM to UCOM. So that's that inter-theater piece, because you're going in between different theaters. Good to go? PMRC, so patient movement requirements, center contact information.
What's that?
These are just
Oh, sorry.
contacts or the locations, so global, UConn Theater, PACOM Theater, just the facilities where their PMRC or patient movement centers are. The system that's used to track these patients that are moved via PMRC or TPMRC or GPMRC is Tracer. So it's essentially you put all the inpatient data in there, so let them know, hey, here's the accepted physician at this facility, this is where they're going to, and they expect your treatment moving forward. So responsibilities and comparison, so flight surgeon, authority for determining whether patients are physiologically ready for air transport, resource for AE information, communication, and coordination. So this goes along with when those patients come up from that respective combat zone to the row 2. That's why the AELNOs are embedded with the medical staff, so that way they can do their assessments, do what they need to do, and make sure that those patients are actually capable of being transported via air to where they need to go. Resource for AE system information. Request versus requirement. So physicians that originate MTF submit requests for movement, timing, and destination. Only validating flight surgeon and the PMRC can validate those requests, which then become requirements. So only the validating flight surgeon and the PMRC can validate those requests. So when you put in your data into traces or that respective put that data in traces and you push it forward, there's a team of people that it goes through to verify before this mission is set in place to be able to transport that patient.
I have a question.
Yes.
What does PMRC stand for?
Patient movement requirements center.
Did I hear the patient before?
Requirements center.
Oh.
So these people are just validating this person is stable enough to transfer.
So, validation versus clearance. So, clearance is a medical care unit, meaning that you've got this patient has sustained these injuries, you talk to that physician, and that physician is going to accept that patient. So that gives you the clearance. Now, the validation is the logistical piece. Now we're moving those air assets to go pick that patient up and take them to where they need to go. Make sense?
So it sounds like they can medically accept them for the treatment, and the other part is making sure they get enough supplies to support that treatment.
The aid process. So request for aid admission comes from the originating physician. Again, that's when you're calling forward and you're getting a physician saying, hey, this is what I have. Just like if you're medevac and casualty from, or you have an injury, you're forward, and it's just you and your platoon. Hey, or your fire team, or you, hey, this is what I have, blah, 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 blah. And then you get that info from your IDC or your, whoever your SMO is, whoever you talk to, you get that before they'll accept it. Does that make sense? So validation, PMRC, and then clearance moved by air. So NTF, referring physician, and local flight surgeon. So again, once they get to that location, that flight surgeon comes to make sure that patient's cleared for flight, and then they'll push them forward. Alright, so steps for request. Contact local flight surgeon, AE liaison, or AELNO for clearance consultation. Determine the patient's AE category based on diagnosis and ability to self-help in an emergency during flight. Determine need for CCAT. So again, CCAT, Critical Care Air Transport Team, is used for movement of stabilized patients who require high level of medical therapy or who have potential to exposure to significant deterioration during movement. So those are for your patients that have that multi-system traumas, and you have concerns about them maintaining airway, they're being hemodynamically stable and be able to transport them. So a 5-person burn transport team can augment the AE system as required for inhalation or severe burns. Determine if special requirements exist for transport, i.e. if you need respirators or any other type of special equipment like that to assist the patient. And that usually comes from whatever surgical team is seeing that patient, because they won't have, obviously you won't have those capabilities at a BAS or at your Role 1. Determine patient movement items required must be verified by a flight surgeon, and determine patient's movement precedence. And then submit your report. Alright, so patients requiring CCAT transport include those in need of intensive nursing care, constant hemodynamic monitoring, mechanical ventilation, you got them on a respirator or someone on the line, a ventilator, frequent therapeutic interventions or other medical or surgical interventions vital to sustain life, limb, and eyesight during movement. Questions? All right, so indicators, intubated, requires aggressive fluid administration, more than 10 units of blood products in the past 24 hours. So again, a major system trauma, this person has suffered severe bleeding, and they have pushed copious amounts of blood. Increased oxygen requirement, unstable spine fracture, altered mental status, electrolyte replacement, unstable angina, everyone knows what angina is, unstable chest pain, and it requires intracranial monitoring. Alright, so this is what I talked about before, the makeup of a CCAT team. So you have your intensive physician, which is usually a PR doc, general surgeon, or some type of emergency medicine-based provider. You have your critical care nurse, and then your cardiopulmonary technician. Like I said before, for management expectation required mechanical ventilation and invasive monitoring. Experience in troubleshooting ventilator support, portable laboratory devices, and monitoring systems.
Is this Air Force personnel or Navy personnel?
Air Force. So this is a transport checklist they'll go through, make sure they have all these things they need. So with this checklist, all right, let's say you have a routine patients that need to get evacs for whatever reason. And I'm using CODJ example because that was just my most recent experience. So what happens is, once those patients have gone through the system, their medevac requests have been placed, they've been validated, their flights have been sourced. What they'll do is they'll meet a couple hours before the flight with the AELNOs or the liaisons, and they'll go through this checklist with them to make sure, hey, they have all these things. And prior to that, those AELNOs have contacted them and say, okay, hey, this is what I need from you, A, B, C, and D. And what they'll do is they'll set them up right before a couple hours before the flight, go through the checklist, make sure they have everything they need, and then they'll take them out to the flight line and push it forward. So humanitarian transport requests. The process of arranging routine humanitarian evacuations out of theater can take more than 6 months.
The question's been on the test before. Make sure you put a star next to that one.
So patients usually have a fixable, stable problem. lack of suitable host nation care must be documented. Then all evacuated children must have an attendant. Those military transport require Secretary of Defense designee status.
That one's been on the test before too. That bullet point.
And clearances must cover both the patient and the non-medical attendant. Alright, any questions?
Can the attendant, does it have to be someone from their host nation, or is it like a mom or dad?
I think it's situational dependent. Yes.
And the acronym for CCAT again?
Critical care air transport team.
I have a question.
Yes.
On the CCAT, so that's not the original team, that's a more advanced team?
Yes.
Okay.
Yes. So the CCAT is a team that's what they do is en route patient care. This is outside of that. Their mission set is changing just because of the ongoing operations, things that are developing throughout the world. But as it stands right now, their primary mission is just in-flight patient care. Yes.
For the homes, are we talking about foreign internationals or military personnel?
These are nationals. Any other questions? All right, that is all I have for you. Thank you. You all have a super great day.
Thank you, Chief.
Indeed.